Good afternoon, everyone. It's my pleasure actually to introduce my friend and colleague, Professor Sean Park, from my clinic Comprehensive Cancer Center. He will be talking about the ultra-hypofractionation practice in breast cancer, current data and clinical integration. Professor Park.
Shukran. Assalamu alaikum. Yes. Okay, thank you. Okay. Yeah, thank you, Nadeem and Fatima, for inviting me to come here and share the talk. It's a wonderful privilege to be here and to be part of this inaugural AMSTRO group. Thank you so much. These are my disclosures, and this is the learning objective. So we'll go over the radiobiological rationale for hypofractionation in breast cancer. Ultimately, it's the low alpha beta of the breast cancer, but also the breast tissue itself also has a low alpha beta ratio. So keep that in mind. And we'll go over the conventional and hypofractionated trials, beginning with the moderate and then ending up with the ultra, and look at the efficacy as well as the toxicity. And then we'll end with the practice integration and conclusion. So this is a case I saw just last week. 62-year-old postmenopausal lady who underwent annual screening mammogram found a small 1.1 centimeter grade 2 invasive ductal at the 6 o'clock position of the left breast. She had breast conserving surgery and found that this was ER/PR positive, PR weakly positive, HER2 equivocal on the IHC, ultimately negative on the FISH. Ki-67 was 60%, margin was widely negative, and 2 sentinel lymph nodes were negative. She has no other medical comorbidities or competing factors except for hypothyroidism, which is well controlled. So why do we hypofractionate in breast cancer? Again, the biological rationale is that the breast cancer has low alpha beta ratio between 3 to 4 gray. So basically, larger fractions over fewer treatments, and the key is to reduce the total dose in hypofractionation. And we also have advanced technology that allows us to deliver highly accurate radiation treatments using image guidance and various techniques listed there. And ultimately, it's a patient-centered advantage, improving quality of life, as you will see in trials, improved cosmesis, similar or improved toxicity profile. Patients have fewer visits and lower the costs. Very few treatments in medicine offer all these qualities. So hypofractionation, as the previous speaker mentioned, moderate hypofractionation, we're looking at 15 to 16 fractions for the breast cancer, and ultra at 5 fractions. Ideally, you want the alpha beta of the organs at risk, the late toxicity, to be greater than the alpha beta ratio of the tumor. But as we shall see, they're both similar in breast cancer, between 3 and 4. And I did the EQD2 calculations here for you, alpha beta of 4, alpha beta of 3 in the right column, and looking at the different trials there. And also, is there a different mechanism of cell death when we increase the dose per fraction? Are we inducing some immune response, as the first speaker spoke yesterday, and also effects on the vascularity? So when we compare the different dose regimens, the conventional versus the moderate hypofractionation versus the ultra, we're going to get the acute effects. But what we're most interested in is months and years down the road in terms of the late effects, looking at breast effects, the shrinkage, induration, and fibrosis. So this is the landmark study from the UK, over 1,400 women, T1 through 3, N0. They did include up to N1 patients. They compared the standard arm with the 2 experimental arms, 39 gray and 42.9 gray. All the fractions were delivered over 5 weeks. So in the 13 fraction arm, it was delivered every other day. Primary endpoint was a late change in the breast appearance in the photo and in duration. As you can see here, these are the outcomes in terms of the primary outcomes. And from this, they deduced that the approximation of their breast in duration alpha beta ratio is 3.1. They also looked at the breast cancer alpha beta. This was not powered, keep in mind, alpha beta of 3.6 gray. And this landmark study led to the design of the START A and B trial. Here, it's important to note that the 5% increment in the total dose, I mentioned that you want to, as you increase the fraction size, you reduce the number of treatments, but also you want to ultimately reduce the amount of total dose. So if you increase the total dose by 5%, there's a whopping 9% increase in breast changes in the appearance. So at 10 years, START A was the randomization of the conventional arm versus the two different hypofractionated arm, 41.6 and 39. And this was designed to estimate the alpha beta ratio of the breast cancer and the breast tissue. And the START B trial, comparing 50 gray versus 40 gray, and the 40 gray was delivered every day in 3 weeks. Two primary endpoints, which is a local regional relapse and the late effects. If you look at the first endpoint of the local regional relapse, there was no difference within the arms between within START A and also within START B. They were equal. And from these studies, it was deduced that the alpha beta ratio for the tumor was 3.5 gray. Now, what about for the late effects? In terms of late effects, there was a statistically significant improvement with the 39 gray arm in START A, as you can see here, with the edema, induration, and telangiectasia is improving there. In START B, there was also improvement in edema, induration, shrinkage, and telangiectasias. So again, for the breast tissue itself and breast shrinkage, the alpha beta ratio was deduced at 3.5 gray, which is the same as the breast cancer. And using the EQD2, the 40 gray and 15 was equivalent to about 45 gray. How about the other organs at risk? All arms, including the standard arm, reported less than 1% of rib fractures, lung fibrosis, ischemic heart disease, and brachial plexus injury. Interestingly, when you look at the START B, there was no difference between the hypofractionated arm and the conventional arm in terms of local regional relapse. There was, however, an improvement in distant relapse in the hypofractionated arm. And this was an unexpected finding, which led to improvement in any breast cancer events and overall survival. And this is kind of makes us think whether the hypofractionated arm, when the dose is escalated, whether we are inducing more immune response against the breast cancer. Another study that supports moderate hypofractionation is the Canadian study. This study compared 50 gray versus 42.5 gray in 16 fractions. Slightly different, more favorable population. They limited the size to less than 5 centimeters. At this time, all the patients in this era, all the patients had axillary lymph node dissection, and they were N0. And to limit the heterogeneity, patients, the separation was limited to 25 centimeters or less. They were stratified by age, by size, receipt of the systemic therapy, and where they were treated. Primary endpoint was invasive local recurrence in the treated breast. And again, as you see in these curves here, there was no difference between local relapse or survival. This was an unplanned analysis. When this paper first came out back in 2010, this showed that there was a difference in the high grade, showing inferior outcomes in the moderately hypofractionated arm. But again, this was unplanned subgroup analysis. And they didn't, for this particular study, they didn't have boost of the cavity, and very little patients received systemic therapy. So as opposed to the START trial, which didn't show this difference in the high grade. Looking at the toxicity, there was no difference in the late skin or subcutaneous tissue toxicity at 5 years and 10 years. And looking at the cosmesis, looking at the good and excellent outcomes compared to the baseline, they fall similarly as we go up from 5 to 10 years, but no difference between the conventional versus the moderately hypofractionated arm. The last study is a Danish hypo study, which included over 1,800 patients. They also included pure DCIS patients, comparing 40 gray versus 50 gray. Again, favorable patients, T1 to 2s. They did also include micrometastasis in the lymph nodes. They did not, if the patient had reconstruction, they were not allowed to be on this study, but the oncoplastic closure was included. The primary endpoint was 3-year, grade 2 to 3 progression in duration, and there was no difference between the two arms. And significantly, the moderately hypofractionated arm had improved cosmesis, dyspigmentation, edema, and sensibility. And the patient satisfaction was high in both arms. As you can see here, the 9-year outcomes, local recurrence was equivalent, no difference, and overall survival is also good between the two arms. So this table just summarizes what I just went over with you, showing that the local recurrences were all similar, no difference between the standard versus hypofractionated arms. In terms of toxicity, either equivalent or better with the hypofractionated arm and better patient satisfaction. So this was a randomized study from MD Anderson comparing 25 gray versus a 16 fraction regimen. These were stage 0 and 1 patients. This was done in Houston. So 3/4 of the patients were obese. Patient-reported outcomes was recorded by FACT-B, and the MD assessed the toxicities using CTC version 4. And you can see the acute side effect profile is superior for the moderately hypofractionated arm in all these accounts here. At 6 months, the moderately hypofractionated arm was also superior at fatigue, less lack of energy, and less trouble meeting all family needs. And the multivariable analysis was still holding for patient lack of energy and trouble meeting patients' needs was superior for the moderately hypofractionated arm. This is a Michigan consortium study, over 2,300 patients, and showing that the MD reported weekly management visits, the acute side effects, and up to 1 week out after radiation. Looking at the skin reactions, dermatitis, they're all superior for the moderately hypofractionated arm. And then for the pros, pain, burning sensation, swelling, fatigue, they were all superior for the hypofractionated arm. Now switching gears to the ultra-hypofractionated, delivering 5 fractions in 1 week. So all these studies that I just mentioned, the moderately hypofractionated randomized studies, showed that the moderately hypofractionated arm is safe and effective, maybe improved toxicity. So how much dose can we escalate per fraction before we start to see adverse effects? So before we go to the fast forward trial, this was the kind of the landmark, the FAST trial with the 10-year outcomes, 3-arm randomization with the standard 50 gray, and the other 5 fraction regimen was delivered once weekly, the 28.5 and 30 gray, included T1 and T2 and zeros. Primary endpoint was change in photographic appearance, and it was worse with the odds ratio of 1.64 for 30 gray arm. And you can see the graph here. So from this study, they estimated the alpha beta for the endpoint was at 2.7 gray. And at 28 gray and 5 fractions was estimated to be isoeffective with 50 gray and 25. And then came the fast forward study. The 5-year was published and the 10-year was presented at the last year's AMSTRO abstract oral presentation. This included T1 through 3, N zeros and ones. Primary endpoint was in-breast tumor recurrence. Majority of the patients had ER-positive disease. Only about 20 patients had node positive, and 1/4 of the patients had a sequential boost. From this study, they deducted that the 26 in 5 is similar to 40 gray in 15, and 27 in 5 is similar to 50 gray in 25. Again, you see no difference in the primary outcomes at 5 and 10 years. However, the normal tissue events were higher at 27 gray in 5 fractions in regards to breast shrinkage in duration and distortion. We're going to switch gears, and I just wanted to bring this study up. The UK import low was looking at the radiation field. So the control arm was the hypofractionation arm, 40 gray and 15. There are two test arms. Test arm 1 was the lower dose to the whole breast to 36 and 15, and maintaining 40 gray to the mini tangents, I call them. And then the test 2 arm was just purely the mini tangents around the lumpectomy cavity and defined as shown there. And it shows that there's at 10 years, there was no difference in the in-breast tumor recurrence. And so, and also the patient reported change in breast appearance, and the breast feeling harder or firmer was lower in the partial breast arm. So bottom line is that this is a great option and easy to be easily adopted to the radiotherapy practice. So what we do at Mayo, and I'm sure a lot of people do this, is that when we see early stage favorable patients, instead of doing the 40 gray and 15 fractions, so we kind of combine the import low with the fast forward dose regimen of 26 gray and 5 mini tangents. So coming back to our patient, favorable luminal disease, early stage, definitely a candidate for partial breast radiation because it's 1.1 centimeter. The location was, again, at the 6 o'clock position of the left breast, which was near the heart. We did do the breath hold simulation, but she was not a great breath holder. And even with the breath hold, the heart was right there. And we can use IMRT or VMAT, partial breast technique, or for an oncoplanar beam arrangement, but they will sometimes dose possibly into the heart or in the lungs. So we did use the import low technique as you see here, and just treat the lower part of the breast, and she tolerated treatment really well. So just to recap, the Canadian study included T1s and 2s and 0s. Danish study included T1s and 2s, included also micrometastases. The STAR trials included T1 to 3s and 0 and up to 1, so up to 3 nodes. Import low was up to 3 centimeters, and they did include N1s, but very few patients were node positive in that partial breast study. So using ultra-hypofractionated radiation, these are the kind of the scenarios I can think of. So if you have a favorable breast cancer patients who are eligible for partial breast, you can use a mini tangent technique as an import low. If they have T1 to 3s and 0, whole breast, 26 and 5. And then when do you use high tangents? Well, sometimes we see patients who have clinically N0 patients, and on pathology, they have up to T1s and 2s pathologically, and then they may find 1 or 2 nodes positive, just like azogoc Z11 patients. In these patients, I use high tangents, and then also encourage patients to receive some sort of systematic therapy, make sure they're ER positive. On that azogoc Z11 study, 90% of the patients either had endocrine therapy or chemotherapy. And then consider boost, as shown in the Barlink EORT study. The younger patients, especially in their 40s and 50s, premenopausal patients benefited the most, but we also consider an ER negative and grade 3 patients. And we do it sequentially. 10 gray in either 4 or 5 fractions. Sometimes if the patients are traveling and they can't stay an extra week, I try to do a SIB technique to 30 gray to the cavity and then 26 to the breast. And I believe that's being studied in the UK trial. So in conclusion, moderately hypofractionated regimen has similar in-breast tumor recurrence rates as a conventional. Side effect profiles shows improved quality of life and cosmesis. And now we have 10-year data from last year's AMSTRO for the ultra-hypofractionated regimen showing similar outcomes in terms of tumor control and side effect profile, as well as quality of life, which results in patient convenience. Well, thank you for your kind attention.
Thank you, Sean. I think we have time to take a couple of questions to Dr. Park. Okay, I have one question, Sean, regarding this patient in the light of the new sound trial where patients wouldn't undergo surgical assessment for favorable histologies and clinically node negative. Considering a similar scenario to your case with no sentinel but node negative clinically, would you still consider mini beam or partial breast radiation?
Right. That's a very difficult situation, right? So you know, with the favorable clinical findings, now we're omitting lymph node investigation at the time of surgery. At Mayo, we have all the patients go through ultrasound of the axilla. So it's not just by palpation. They're clinically node negative by imaging. So even within our breast practice group, we have a little bit of split in this area. For me, if the patients are in their 70s and they're node negative but clinically with ultrasound, I do offer a partial breast technique in these patients, even without the sentinel lymph node. But others will not. So it's a controversial topic, yeah.
We have one more question here.
Yes.
Yeah, go ahead, Dr. Reem.
All right, Dr. Sean from here. So,
over here.
Yeah. Regarding maybe you did not talk directly about this, but the fast forward nodal sub-study. So with the result being published, are you considering or started practicing giving the ultra-hypofractionation with nodal irradiation?
Yes. So I didn't have enough time to go over the node positive patients. I just focused on the early stage patients. Definitely, you can use a moderate hypofractionation for node positive patients in 15 or 16 fractions. That's our now center of care in our institution. For 5 fraction ultra, I do consider that because we have protons. And so with the protons, we could really limit the amount of normal tissue that receives the prescribed dose. And I do believe there's a volume and tissue effect, then dose effect. So with protons, I'm very comfortable delivering the 5 fraction regimen, and including the nodal regions.
Thank you, Sean. Dr. Sahab, go ahead.
No, this one? This one. I made this up.
Yeah, go ahead, please.
Mm-hmm. Yeah, so that's a very good point you bring up. I feel very comfortable with postmenopausal women with the 5 fraction regimen. Before last year, before the 10-year data came out, I'll be very with the 5-year published data. I was very cautious to offer women in their 50s, even 60s, where they have many decades to live. And I would have a very frank discussion telling that there's no difference at 5 years. We don't know what's going to happen in subsequent, follow-up. And then when the 10-year, actually, even before the 10-year data came out, I would have a shared decision-making with the patient with the 5-year data. And again, a lot of our patients come from outside, and staying 3 weeks versus 1 week. Many patients say, "I just want to stay 1 week," and knowing that it was only a 5-year follow-up. But with the 10-year follow-up, I feel more comfortable offering it to the premenopausal women. But I still have them a discussion that this is still 10-year follow-up, and it's the newest thing, and that's why it's the shortest follow-up. But I don't think the curve will start separating. After 10 years, so magically it's going to go this way, right? I think it's going to go together. That's what I envision. And so again, shared decision making for younger women.
Thank you.
Yeah. So for T3s, yes, you might consider strongly, and then also younger women as well.
Thank you, Sean. I think
Okay.
we can take one last question. Go.
Yeah. So I didn't include any of the node positive patients, but yes, we do treat node positive patients with moderately hyperfractionated using either 15 or 16 fraction regimen, but not with the 5 fraction regimen. Yeah, we most of our patients are reconstructed with a tissue expander, and we radiate the tissue expander.